I'm now delighted to welcome our third speaker for the session, and that is Norbese, I hope I haven't mispronounced it, Ms. Flint, who serves as the Policy Director at the Black Women for Wellness and as the Executive Director of Black Women for Wellness Action Project. And we're looking forward to your remarks. Thank you.
Thank you. I am so happy to be here. I've learned so much over the last couple of days. And so I will be talking a little bit about our California Dignity in Pregnancy and Childbirth Act, as well as maternal health policy, some other maternal health policy that we have been working on. I'm the policy person. I love policy. Probably to a weird degree because I am a nerd. So I can't wait to get into some questions and discussions after I give this small but short presentation. Next slide, please. So again, for folks who are Black Women for Wellness, the font's messed up a little bit, but Black Women for Wellness is a reproductive justice organization that has been around since 1997. We are in South Los Angeles, and one of our first programs were looking at maternal health and infant health because the rates were so high of death of maternal and infant health deaths for Black folks. Black Women for Wellness Action Project is our 501c4. That's where we run our political and policy out of, and it's got established in 2017. I won't go into reproductive justice because the folks did so eloquently yesterday, and just move on to more of the substantive part of the presentation. Next slide. So just to give a little bit of a landscape of what was going on in California before we started some of our policy pieces in this last run. California is very looked at as like kind of the shining beacon in the light. We are like, oh, well, can we be more like California in terms of our maternal death rates? For the last 30 years, we saw a reduction in death rates overall in California. But what we haven't seen is a reduction in the disparities of Black women with the state's average. And so the last time we got data, which was in 2013, Black women were at 26.4 per 100,000, which is almost 3.8 times higher than that of white women. In Los Angeles County, where we have more updated data, that is actually 4.5 times higher. With our latest piece, 2018, that Black women were at 85.8 per 100,000 the maternal mortality rate, which again is not only much higher than what we think the state is, but that disparity between Black women and white women, but not only just white women, just the average in California is in Los Angeles is much, much higher. Our infant health rate, again, is looked at as a shining beacon, but if you dig deep into those rates, you see that Black babies and Native American and Indigenous babies are dying at higher rates, not only just in general, but also in different geographic places. Both in Fresno, Native and Indigenous babies and Black babies are somewhere in between like the 20s per 1,000 live births. So we know that disparities are happening across the state, and they're getting buried in our overall kind of good numbers. Next slide. The other thing is, we've done some research and some conversations with people, I'm going to say we and not Black Women for Wellness, but we as in California and folks who do this great work here, talking to people about what their experiences are. And we know that Black and Indigenous feel mistreated. We know that they're scared and there's a fear with going into docs. We know that there's a high number of people who report unfair treatment, a high number of people who are looking for folks to help them in different languages. We also know that California hasn't published updated data in a very long time. And so when we say that this is like, again, we have these great numbers, we also don't know where we're going with those numbers right now. California doesn't have a codified MMRC. We do have a perinatal collaborative, but there's no requirements to address racial disparities. There are no requirements at all since it's not codified in legislation. And we also are facing an OBGYN workforce shortage, where we have many of the places in California are deserts or have between 1 and 5 OBGYNs. To put that in perspective, California has somewhere between 38 to 40 million people. So 1 out of every 9 people in the United States live in California, and in some of these counties. Again, when you're looking at low numbers, when you're looking at low numbers, you're also talking about low numbers in places that have really high populations. Next slide. So what do we do? So these are a couple of pieces of policy that we had created and went through for Black Women for Wellness. One of the things, and I'm going to go a deeper dive into SB 464. This is not a comprehensive list of maternal health policy that we have done, but I just want to hit on a couple of pieces in both SB 464 and SB 65. SB 1237, which got passed last year, was a bill that essentially removed physician supervision for certified nurse midwives. We were one of only 4 states that still had that on the books, and we only got that off last year. Next slide. So what is SB 464? Though we'll talk a little bit about the history before I jump into what's in the pieces of it. SB 464, our California Dignity and Pregnancy and Childbirth Act, was an attempt from us to look at how do we start addressing discrimination and racism within the system of maternal health right now. We talked to people across the country. We were looking for anybody who had some policy pieces on what does it look like to close the gap around racism. And there just wasn't a lot of policy that was written that's been tested. So this was our attempt to test out what it looks like to do an evidence-based implicit bias training. Now, I do say implicit bias, but what we wanted to do was to bury essentially a racial justice training within an implicit bias framework to actually really push our physicians, our all perinatal staff actually, into the thinking about racial justice in a different paradigm. The pieces of the bill, well, it took effect, we got it passed. It took effect January 1st, 2020. However, there were 4 pieces of it. One was an improved death certificate reporting for more accurate maternal death counts for California. This is particularly important because we were missing a lot of data, which is one of the reasons why we don't report to the CDC. On the way the CDC leaves out most of our data when it comes to maternal deaths. We require publication of maternal morbidity and mortality data. Again, we haven't got any good data for a very long time, so we wanted to know where that is and what's going on. So not only the data needs to be disaggregated by race, but also we wanted to see clusters to see if there are any problematic area. It also mandates community education about ways to report experience of healthcare associated deaths and discrimination. Excuse me. And so we ask essentially for the hospitals, birthing clinics, to let folks know what the process is about if you've experienced discrimination, how do you report that? And this is in addition to the implicit bias training. Next slide. So what was in our implicit bias training and how do we set up? The vision, or what we envisioned and what we hoped for with the implicit bias training, was that folks would start to do this in-house. And so we weren't very prescriptive of who should be doing the training. We were more prescriptive of the curriculum of the training, where we had, again, talked to some of our partners across the country to see what are the important pieces of an implicit bias training. So these are the 10, and identifies previous or current unconscious bias and misinformation. This is our way of having people take an implicit bias test. It identifies personal, interpersonal, institutional structures and cultural barriers to inclusion. One of the things that came up when we were talking to folks is that not only was there racism experiencing between patient and providers, but there is also between the different providers and staff on the perinatal space. So whether that was nurse, our front staff, with doctor, our midwife, that all of these things were also happening as well, and that they were having a tough time having these conversations as well as a staff, and not only as with both staff and patient. We also wanted to make sure that there was some corrective measures to decrease implicit bias at the interpersonal and institutional levels. We wanted to make sure that there was some inclusion of folks who experience this space. And for those conversations to happen, we had added one of the first places in any legislation to mandate education on reproductive justice. And we also had the stat for is to do every 2 years, because again, from what we talked to folks about, they said that this needs to be an ongoing piece. We couldn't actually get it under the 2-year space. I'll talk about that in a minute, but we thought that was at least enough to reoccurring time for people to understand keeping the conversation around racial justice in their atmosphere. Next slide. So lessons and opportunities. So we were really excited. This would have been, not this year, last year would have been the first year that we would have rolled out this training and mandated for all perinatal staff. Unfortunately, COVID happened. And so the shift from folks thinking about how do we look at racial justice went into how do we address COVID-19. So when we did a preliminary conversation with folks, it just seemed like not a lot of folks actually started implementing this in the way we hoped. And so that's a conversation that we're trying to push more in 2021. The other pieces that we learned while we were doing this legislation was that physicians in particular, because of their the way they are classified as workers in California, which most of them have admitting privileges and they're not like employees, that it was not only hard to make them accountable for this training, it was hard to make them accountable for any of the employment trainings that we have in California. And so we're still been thinking through what are those ways in which there can be some more accountability in those places, because not only were we hearing there are problems with our stuff, we were hearing problems with like sexual harassment training and all these other pieces that were happening. We also unfortunately started a budding new industry of folks who are saying that they're able to give implicit bias training. We have seen some of those trainings that folks who said that they are able to give it. We definitely wanted and envisioned this as an in-person training, not something you can do in an hour on an online course. But we've seen a couple of folks who have offered an online course in order to do this. And our thinking in the design of it was we wanted people to be in space with each other, to be able to have these discussions, not kind of clicking through an online piece where we don't think that are going to get much learning in that space. As well as we're thinking of ways to explore funding through budget process to incentivize smaller hospitals to provide rigorous and robust information around implicit bias. And so that means we were thinking about how do we get budget pieces into our, well, not how do I say that? How do we get some money to smaller hospitals to make sure that they are able to pay for these things and incentivize them to actually have a robust training in-house. Next slide, and I will be finishing up in 2 seconds. This is my last slide. So what now? We know that SB 464 was just the beginning. Right now, there's a long road for us to go for SBs for policy and maternal health in California. We do now have a SB 65 California monobus that is working its way through the legislature. I'm just going to highlight a couple of pieces. One, that it established and codifies MMRC in California, as well as create accountability and also diversity and the people who are on that board. So we're very excited about that. We also had extending postpartum care and CalWork supplements. One of the things that we were very excited about that is like 3 or 4 pieces of this actually ended up, or it looks like it's going to end up in the budget. So we're going to get the doula care for Medi-Cal participants. And that will be, it will be a state benefit. So again, that will be super exciting because everybody who is on Medi-Cal starting in 2022 will be able to have a doula. And then there's a couple of other pieces that we're looking at in terms of doing some of the social economic pieces that we want to lift up low-income pregnant folks to have them whole. With that, I think the last slide just is my information. And thank you all for this wonderful chat today.